All right, Casey, I think I saw that it switched over. We're live now.
We have 108 folks in the call and some more filing in.
Okay, awesome. Thank you so much. I will give you guys just a couple more seconds here to file in, and it's so exciting to hear that our numbers are already over 100. That's fantastic. Thank you for being here. We will get kicked off here in just a moment, and we will be recording this session as well so that we can have access to this to share with any of our partners that may not have been able to be here today for the live session. All right, welcome everybody. We're really excited to have you all here today. My name is Sam Robleski. I'm joining you from the state of Michigan, where it is very snowy and cold, and I'm sure most of us in the Midwest are enjoying lovely ice and wind and all sorts of storms. But we are excited as a collaborative team from the Midwest to welcome you all here this afternoon for this special session. We're really excited to have team members from the NPRQI come join us for a special informational session to teach us a lot more about the QI initiative that is available to any of you who are on the call today, who are coming to us from emergency departments across the country, but hopefully from across the Midwest. Our Midwest EMSCs, oh, sorry, was that a question or an issue? No? Okay. Cool. Our Midwest EMSC State Partnership Program Managers like to collaborate on opportunities to bring you education, resources, and support to tackle pediatric readiness initiatives that you may have or be desiring to take on in your department. This specific resource is really valuable, specifically for rural critical access and smaller emergency departments that may not have access to robust QI opportunities through their own health system or partner organizations. There's quite a few things that we're going to learn about today from the NPRQI team, and we're really excited to hear from them so we can find out how we can seize this opportunity to close pediatric readiness gaps together collaboratively across the Midwest. So I'm going to share just a couple things so that you know who Midwest EMSC is, and then we're going to hand it over to the NPRQI team. On your screen, you'll see a list of several states, and we've all been working together for years at this point to bring those deliverables to you. But these are the states that work hard to do so. If you're not joining us from one of these states, but from outside of it, we welcome you and we don't want you to leave. Please stay with us. There's no credits or anything that you need to do today. It's purely informational, but we just wanted to let you know who was able to pull together this opportunity. And I certainly don't expect you to remember everything on this screen by any means, but we wanted to show you your state partnership managers so that you know how to connect with us after this session or in the future if you need any pediatric readiness support specific to your state. At the end of the presentation today, there's going to be opportunities to talk to the NPRQI team specifically about their presentation and the quality improvement collaborative opportunities. After that wraps up, I'll pull this screen back up at the very end so you can feel free to take a screenshot or jot down your manager's name and email address if you want to get in connection with us. And with that, I'm going to hand it back over to you, Casey, for the NPRQI team to take on over.
Thank you very much. Just swap this in here. All right. Well, good afternoon or good morning, everyone. My name is Casey. I would like to thank you all for being here. I am a program coordinator with the EMSC Innovation and Improvement Center. And today I'm joined by my colleagues Lisa Hinojosa, Doctors Kate Remick, and Sonia Desai. I will have them introduce themselves here in a minute, but we do look forward to sharing with you all a bit about how participation in a quality improvement collaborative can help your emergency department improve your pediatric readiness. Now, before we get started with today's session, we would like to acknowledge that the EMSC Innovation Improvement Center is funded through a cooperative agreement with the Health Resources and Services Administration, which is within the U.S. Department of Health and Human Services. Additionally, NPRQI is also supported by the Toyota Way Forward Fund, and the contents of today's presentation are those of the authors and do not necessarily represent the official views of nor an endorsement by HRSA, HHS, or the U.S. government. Now, I'd like to hand things over to Dr. Kate Remick, who will walk us through why pediatric quality improvement is so important.
Great. Thank you, Casey. And thank you, Sam, for getting us started and inviting us to join you all today. We're really excited to be able to share a little bit about the National Pediatric Readiness Quality Initiative and hope it'll help support all of you in achieving high levels of pediatric readiness. I am both a peds emergency medicine and EMS physician. I'm based in Austin, Texas at the University of Texas, and I serve as co-director for the EMSC Innovation Improvement Center as well as NPRQI. So it's great to be here. So let's dive in. Why quality improvement and how does it help support pediatric readiness? If you could go to the next slide, please. So I think many of you know that somewhere over 85% of children do not seek emergency care in children's hospitals. They go to general emergency departments that are close to home. And because of EMTALA and also just ethical and moral obligations, we are required to be able to support those children who present at our doors, whether we're ready for them or not. The challenge, of course, is that the majority of emergency departments see fewer than 10 pediatric patients per day, which means that we don't see a lot of high risk, low frequency events. Instead, we see more common events, and it makes it really hard for us to prioritize those specific equipment elements, supplies, the training we need, the systems we need to have in place in order to meet the needs of those really critically ill and injured children who come to our ED. And as many of you, I think, already know, is that pediatric readiness is really about improving the systems. It's not about a particular care team, a particular physician or a nurse's training. It's about the entire system that's in place. And I often speak to the fact that, you can take the best doctor, the best care team in the world and put them in a tent with very few resources, and they are going to fumble and they are going to perform poorly. And so our goal is really to improve pediatric readiness at a systems level. Next slide, please. So, when it comes to quality improvement, we know that it is one of the most important drivers of pediatric readiness. Quality improvement is really the idea that you're looking at how care was delivered to specific pediatric patients that presented to your emergency department. And ideally, we are doing what's known as continuous quality improvement, which means we're constantly looking at how care is being provided to identify when we have missteps in the overall care of, the pediatric patient. It is truly the leading driver of pediatric readiness. When we look at national pediatric readiness scores and we look at those emergency departments that have a full quality improvement plan in place, they have an average adjusted 25-point increase in their overall pediatric readiness score. That means if you took out the points related to having a quality improvement plan, normalize that to a 100-point scale, they would score on average 25 points higher. And that means it has the ability to really propel an emergency department that's in the lowest quartile of readiness to the highest quartile of readiness. Why is that important? Well, we now know that those EDs that have high levels of readiness have as much as a 76% decrease in mortality for critically ill children who present to those emergency departments. That level of mortality risk reduction is huge and far exceeds what we've seen at stroke, STEMI, and trauma centers across the board. Next slide, please. So, if all of our emergency departments could be pediatric ready, then we could save as many as 2,100 lives or more every year in the United States. And so, really, the National Peds Ready Project is designed to really help support all EDs to achieve high levels of pediatric readiness. As many of you know, we do that through national assessment. We have one coming up in 2026. It'll launch in March. We do it through a number of resources like the National Peds Ready Toolkit, where we can identify gaps, including gaps such as quality improvement, and then providing the resources and the tools to be able to engage in those improvement work and hopefully to improve our pediatric readiness score overall. And that's really what the National Peds Ready Quality Initiative was designed to do, was to really provide that opportunity to improve your pediatric readiness score through quality improvement. Next slide, please. So this is really what we call the roadmap to pediatric readiness, and it's really intended to be very broad strokes, but to help people understand how do you even start to engage in the National Pediatric Readiness work. And the first step is really beginning to look at what the pediatric readiness standards are, getting ready to take the actual national assessment, look at that assessment, identify gaps, opportunities, ensure that you have a pediatric emergency care coordinator in place, and then all the efforts that we have all been undertaking now for many years to improve our overall pediatric readiness, get to a sustainable level, and ideally to get recognized. There are many states now that have pediatric readiness recognition programs, many states, particularly in the Midwest. And we encourage you to work with your EMSC state partnership programs to ultimately become recognized so that you can demonstrate externally to your community that you are committed to pediatric care and then to be able to keep that up over time. Next slide, please. So there are a number of barriers that we are well aware of to implementing pediatric quality improvement, and that has a lot to do with the fact that most emergencies see just a few pediatric patients on a regular basis. And we recognize too that many emergency departments don't have personnel that are trained in quality improvement. They may not be pediatric specialists in particular. They may not have the IT and technological resources to be able to support some of this work, in addition to the many competing priorities of being other types of centers, specialty centers, federally designated centers, and the like. And we understand that quality improvement can be challenging to maintain over time without that support. And that was really where the National Peds Ready Quality Improvement Initiative was built upon this, is trying to give you all the tools at hand, free, open, and readily available to you so that we can overcome some of the legwork of developing quality improvement programs. Next slide, please. With that, I'm going to turn it over to Lisa Hinojosa, who's going to talk to you a little bit more about what is this NPRQI that we're talking about.
Thank you, Kate. Hello, everyone. Nice to see some familiar names and faces, as well as some new ones. For those of you that are new to NPRQI, I did want to share some information about who we are and how we support pediatric readiness. The National Pediatric Readiness Quality Initiative is a free, self-paced quality improvement data platform designed specifically for emergency departments. What we do is help EDs to measure, reflect, and improve their performance on the most key pediatric processes in a secure way. One of the biggest benefits of using NPRQI is that it gives hospitals a framework for continuous quality improvement, which is essential to improving pediatric readiness and making sure that kids get the best care possible. And here's why this tool is so important. It helps EDs to track their progress while they're implementing quality improvement projects in real time. Without NPRQI, it can be hard to know if the changes that you're making are actually moving the needle toward pediatric readiness. Ultimately, NPRQI is designed to inform and empower frontline staff so that they can have the insights and the tools to make real improvements. Next slide, Casey. This slide is a visual representation of the implementation of the flow of NPRQI. So it really begins with accessing the free, secure, web-based platform, being able to capture pediatric patient encounter, being able to then visualize your pediatric emergency care performance on a dashboard. So you're actually able to measure your performance so that you can be informed and be able to transform your data through quality improvement strategies. And then again, coming back and measuring and seeing that improvement over time, reflecting on that improvement and ensuring that what you're doing is really aligning with high pediatric pediatric readiness strategies, and then ultimately really being able to improve and drive results. NPRQI was specifically designed for frontline care teams in mind. There is no quality improvement experience that is required or needed. There are no C-suite financial resources. It was really built for multidisciplinary collaboration, and it's not particularly physician-centric, but we do have physicians that do participate. And I'm going to hand it off to Sonia.
I'm going to chat with you all a little bit about what we measure in NPRQI. And so one of the challenges with doing pediatric quality work is that it's hard to know where to begin or what to measure. And what NPRQI provides is a comprehensive list of about 28 measures that were created and whittled down by a panel of national subject matter experts with the focus of improving the care for every kid that comes through your ED. So we are not focusing on those sepsis or the severe traumas. We're focusing on every child, common encounters, common presentations. And as you might see, the areas of focus here, which are assessment, which is assessment of vital signs, pain, and weight, transfer, blunt head trauma, seizures, respiratory vomiting, and suicidality. These are all based on patient presentations, so on the unpackaged patient that you see, rather than on the final diagnosis. So we want these measures to be applicable to as many patients as possible that come through your ED, not just the really sick ones. Next slide, please. We also want to focus on the care as provided throughout the encounter. So starting with how you assess every child that comes through your ED, determining the appropriate diagnostics, the interventions, such as medications, and airway support, and then finally the disposition, whether you discharge or transfer the child. Next slide, please. We wanted to walk through a quick case study with you all, just to give you an example of how a hospital might use NPRQI. And so for that purpose, we created a fictional hospital, Rite Aid Hospital, which treats approximately 2,500 pediatric patients in their ED annually. They're very interested in improving their pediatric readiness, but like many of our participating sites, they don't necessarily have a designated pediatric champion. And they don't really have anyone on staff that has experience with pediatric QI. And this is the type of hospital that we are focused on. Next slide, please. So in order for this site to get involved with us, we would recommend that they register with the NPRQI platform. And then once they do that, we ask them to collect what we call baseline data, which means let's understand how care is delivered in your ED right now, without any QI interventions, without any efforts. What is going on in your ED right now? So we ask our sites to usually go in and sample about 10 charts a month, 10 charts a quarter, whatever feels good. And when they get to about 30 charts, come back and meet with our NPRQI team, and we'll help you interpret the resources that you are able to see on the dashboard. And what we'll help you do is compare how you're performing with other hospitals to identify where you should begin to focus. And so let me illustrate that with the next slide. So this is an example of what the table view on the NPRQI dashboard looks like. As you can see, these are the 8 core assessment measures and transfer measures listed here. And this is usually where we start with a site that has never done pediatric QI before. And what you notice is that there are 3 columns of performance. The first column is that site's performance on the measure. And then the second column is the national performance. So that is the average performance of all sites that have entered data in NPRQI. And we have about 130 something sites that have contributed data so far. And then I think what's really key is the cohort performance column, because we know it's not fair to compare a site that sees 2,500 patients a year in their ED to a site that sees 50,000 patients in their ED. So we have created performance cohorts that are based on how many children are seen in your emergency department. And so this site, Rite Aid Hospital, is a medium volume pediatric ED. So they see between 1,800 and 5,000 children a year. So that cohort performance reflects how are other hospitals that see about that many kids a year doing on those measures. So if you look at this dashboard, you'll see that if you look at the first measure for weight, the Rite Aid Hospital is actually doing much better than the national or cohort performance. So that's not necessarily an area where they would want to focus their QI efforts. But if you then look at that second measure, the percentage of patients with pain assessed, you'll see that the performance for Rite Aid hospitals at 54%, which is quite a bit lower than both their national and cohort performance. So if you meet with us, we can chat with you and talk to you about, does it make sense for your ED to start working on this? Is this your first area of focus? So this dashboard is really meant to help you identify where to focus. Next slide. In participating with NPRQI, you also have access to several resources. And one of those resources is really ideas for interventions so that you don't have to reinvent the wheel. We have had sites participate in previous collaboratives. We have a resource library of interventions that you could tap into. And so talking through what makes sense to implement in your ED. Is it education? Are you going to train folks on ensuring that to complete triage, you want to ensure that pain is assessed during triage? Is there a new policy that adopts validated pediatric pain scales? Is your site able to make changes to your EMR to create an alert such that if you're trying to discharge a patient and there's no pain documented, you want to ensure that that is done? So these are just examples of things a site might do or might choose to undertake. But then when you think about quality improvement, you always want to answer the question, are your changes moving the needle? Similar to what Lisa said. Is doing all this work associated with an actual improvement in your performance on that measure? Next slide, please. And so that's the second component of the NPRQI dashboard. We have a function that allows each hospital to track their performance over time on any given measure. So this requires that you enter a certain number of records on an ongoing basis. So you'll need to enter variable records for patients. You need about 10 charts to get a data point on our graph. So whether that makes sense for you to do 10 charts a month, 10 charts a quarter, whatever makes sense for your hospital. Entering that data in an ongoing fashion, and then we'll demo the graphical view so that you can compare how you're performing over time and evaluate your strategies accordingly. Next, please. So this is an example of what the graphical view looks like. As you can see, there's a menu of options. We've selected the pain measure since that's what we're working on. You see the performance on the left-hand side in percentage points on the y-axis, and then on the x-axis, you'll see time. So this site is entering about 10 charts a quarter, so we can see how they did. And you can see that the performance was about 40% in quarter one, it went up in quarter three, and then it's kind of trending back down in the next year. What you can do then as a site is look at when did you do your various interventions? What happened when you did education? What happened when you put through that new policy? Why did things start to plateau back down? Is it now time to put in a new strategy of EMR optimization? So that's really QI in a nutshell, done at your ED, and we kind of do all the work, the math, the displaying for you, so that you can focus on implementing the changes in your ED. And so just to summarize, the benefits for EDs participating in NPRQI, it allows you to assess your performance on the nationally vetted pediatric quality measures. We haven't had measures like this before that can be applied to any emergency department. It allows you to track your performance over time, as well as benchmark how you're doing against, folks within your state, your national performance within your cohort. And then it really allows you to demonstrate how your performance has improved. And in doing that, if your state has a pediatric recognition or verification criteria, this helps you get there with the QI requirement. So that's all I have. I will transition back to Dr. Remy to talk about quality improvement collaboratives.
Great. Thanks so much, Sonia. So that's the National PEDS Ready Quality Initiative in a nutshell. And certainly anyone is able to enroll in the National PEDS Ready Quality Initiative regardless of participation in a collaborative. But many of our sites who are just embarking on the world of quality improvement find it very helpful to join what is commonly termed a quality improvement collaborative, really an opportunity for hospitals all over the country to come together and work together to implement and drive those improvements. So next slide, please. So quality improvement collaboratives are really kind of just what they sound, collaboratives for engaging in quality improvement, and they're shared learning networks, meaning that all of the hospitals or sites that participate will create a team, and those teams will join in the quality improvement collaborative to work within their own emergency department to implement strategies to drive improvements in pediatric care. Typically, those teams are multidisciplinary. We usually have a combination of physicians and nurses. In smaller hospitals, it may be just one person. Ideally, it's two, usually a physician and a nurse. But in some of our larger hospitals, we might see teams of 3 or 4 individuals who are working collaboratively to drive those improvements. And during the course of the collaborative, not only will you be supported and kind of guided into how to get started and how to assess baseline performance, what strategies you might choose, but ultimately you get to hear from other sites and learn from other sites about how their work is going, whether they've been able to be successful in driving improvements, whether they're facing barriers, how they're approaching those barriers and steps to overcome them. And certainly within our QI collaboratives, there's no required quality improvement training or experience. We really give you all the tools and resources you need to kind of walk through this process. Next slide, please. So all of our quality improvement collaboratives are based on the Institute for Healthcare Improvement Breakthrough Series model, which is a well-described model for addressing and overcoming gaps. But more specifically, they're focused on common gaps in pediatric readiness, and that's based on what we've learned from the national assessments in pediatric readiness. In addition to focusing on those gaps, we do offer coaching, as you heard from Sonia. So one-on-one coaching, you can sign up for 20-minute sessions, learn from a subject matter expert or a QI coach about how to really drive this work forward, certainly learning from each other. And they were really intended to support local pediatric emergency care coordinators. Now, whether or not you or the person at your hospital carries that formal title is not important, but that's really the intent, is we're helping support those individuals who are working to improve pediatric readiness at their sites. And during the course of the collaborative, using the NPRQI platform, you're able to track your progress, interpret and analyze your performance over time, and really be able to benchmark your hospital's performance, not only against the national cohort of sites participating, but also in cohorts that are similar hospitals. And hopefully this allows you to really drive improvements over time that ultimately results in lives saved. Next slide, please. So the IHI Breakthrough Series model, I mentioned this. So the Institute for Healthcare Improvement is a well-known, well-established national leader in quality improvement. They actually coined the term the model for improvement, which is what are we trying to accomplish? How will we know that a change is actually improvement? And what change can we make that results in improvement? And using this model of improvement, they're really guiding hospitals to go through what we term plan, do, study, act cycles. So if you take the example that Sonia provided, which was focusing on pain reassessment, how do we make improvements? Well, what you might have learned as Rite Aid Hospital, that initially only 40% of children who presented to our hospital had pain reassessment documented within 30 minutes. So what can I do to make improvements? Well, at a local level, you might say, well, maybe a simple and rather easy change to implement is to create a triage checklist that includes pain reassessment. So we'll place that reminder there. And then we'll measure compliance after a week and see if we've made any improvements. In this case, seeing improvements to 65% of children who present, and then eventually be able to expand that much more broadly across the emergency department. So that's really what quality improvement collaboratives focus on, is really helping to guide sites through implementing these plan, do, study, act cycles where you can see measurable improvements with each cycle or each intervention strategy you implement. Next slide, please. So with that, I'm actually going to turn it back over to Casey, who's going to talk about the upcoming EMSC and NPRQI collaborative.
Thank you all for helping to lay the foundation of how pediatric quality improvement plays an important role in pediatric readiness and the ways in which a quality improvement collaborative can support an emergency department doing this work. Again, today I am excited to share with you this important opportunity for emergency departments. It is the launch of the EMSC NPRQI collaborative, which was formerly known as the PRQC, coming in January of 2026. This initiative is completely free and is designed to support emergency departments in deepening their quality improvement work and strengthening pediatric readiness while collaborating with other EDs from across the nation. The EMSC NPRQI collaborative supports EDs in transitioning from simply identifying gaps to making measurable improvements in pediatric readiness. This is based on the IHI Breakthrough Series model, and the collaborative guides EDs from identifying those gaps to implementing improvements through that structured QI method with expert coaching and peer learning. So here's a little bit more about how it works. Your ED team will work together to pick one of our 4 clinical focus areas to focus on improving. This ensures that your efforts are targeted and impactful. We then provide multiple touch points for engagement, opportunities to learn from our subject matter experts, as well as your peers during collaborative sessions, fireside chats, and opportunities for one-on-one support. You'll use that plan, do, study, act, or PDSA cycle to test your ideas, refine them, and make improvements that stick. While teams spend time implementing and assessing local improvement efforts within their ED, collaborative sessions serve as a forum for all participants to gather virtually and share their successes and challenges. By joining the EMSC NPRQI collaborative, you'll have access to support and coaching to help guide you through the process. Now, adding to what Lisa shared about NPRQI, the National Pediatric Readiness Quality Initiative will help your ED measure, benchmark, and improve your performance on our key pediatric processes, providing that clear framework for continuous quality improvement. This tool is so important for the collaborative because it allows EDs to track their progress while implementing quality improvement projects. Without NPRQI, it's hard to know if the changes you're making are actually moving that needle. So ultimately, NPRQI helps to inform and empower your frontline staff so they have the insights and tools to make real improvement. The EMSC NPRQI collaborative is designed to give every ED the flexibility to focus on what matters most for their patients while providing support and resources. You'll choose one of our 4 clinical areas of focus, either pain assessment, abnormal vital sign reassessment, suicide assessment and management, or head trauma, which are utilizing one or more of the NPRQI quality measures. And you won't be doing it alone. We provide free coaching and NPRQI platform support, access to the real-time NPRQI dashboards with national benchmarking, professional development credits. You'll also have access to the collaborative sessions, fireside chats with pediatric readiness and quality improvement experts, plus that peer connection with EDs like yours. This slide highlights some real feedback from past participants during our previous cohort. Their experience shows the practical value and impact of being a part of this effort. Participants have shared with us that even as a small hospital participating in the collaborative, they felt less alone when hearing from larger centers who were experiencing the same challenges, stating that they found it a motivating experience, while others found it to be beneficial to be able to adapt resources and best practices from those higher resourced EDs and apply them with their staff, providing them with tools they wouldn't have had otherwise. And participants also shared that through the utilization of NPRQI, they had access to national benchmarking, which provided them with the data to help drive their quality improvement and strengthen their ability to communicate results with leadership. It's clear that participants have found value in connecting and sharing best practices. So let's talk a bit about how you can get involved and make the most of this opportunity. The next section will walk through the steps to get started. Again, starting next January, our collaborative will be structured in 4 phases, guiding teams from orientation to lasting improvement, building upon each stage to help ensure that progress is both achievable and sustainable. We start by getting everyone set up. Teams will gain access to NPRQI to begin enter their their baseline performance and attend fireside chats on their selected area of focus. This is also when you will review our intervention bundles and your baseline data. Next, you will complete the 2026 NPRP assessment, attending collaborative sessions, and begin planning for your quality improvement project. During phase 3, teams will begin implementing PDSA cycles with ongoing coaching and support. Additionally, data entry will continue throughout this phase so you can monitor your performance and identify changes that result in improvement. So then finally, we focus on sustaining your gains and planning for long-term success while reviewing opportunities to stay connected and continue learning. To get started, you can begin by engaging your ED leadership and staff. We have some promotional materials that you can share to help get them excited about this opportunity to help improve pediatric readiness. If you are new to NPRQI, you'll first register for the platform and share with us that you're interested in participating in the collaborative. You can join anytime between now and January of 2026. If you already have an NPRQI account, you can email us at collaboratives@emscimprovement.center to enroll. We'll share that all with you shortly. And once you've signed up, you can begin assembling your project team, making sure to involve your ED PEC and other members who represent different roles within your ED, whether that be nurses, physicians, administrative staff, child life, quality improvement specialists, or health informaticist, just to name a few. And as Kate mentioned, sometimes our teams are just a team of 1, depending on the resources you have at your site. You can get started today by utilizing our information and promotional materials to help spread the word and sign up with NPRQI. Then you can start building your team. And remember, we're here to support and provide guidance to help make this a successful experience for you and your ED. So thank you very much for your time and attention today. We truly hope that you'll be joining us in January for the launch of the EMSC NPRQI Collaborative. We do have some time to take any questions you all have. You can use the Q&A feature, or if you would like to come off mute, you can raise your hand virtually and we can hear your question from you.
Casey, we had a couple of questions. One pertaining to the schedule for the collaborative meetings. Is that going to be shared at the launch in terms of the cadence of the meetings?
You can find our sessions on the EMSC and PRQI collaboratives pages. There's a sessions details and informations page, but our collaborative sessions are monthly. They are hosted on the 3rd Tuesday of every month at the same time. So you'll register once and you'll get the Zoom information for the entire meeting series. During our first 3 months of the collaborative, there are what we call these fireside chat sessions. And those are an opportunity to engage with our subject matter experts on those 4 areas of focus. Again, those are pain assessment, abnormal vital sign reassessment, head trauma, and suicide assessment and management. So there will be 4 additional sessions to get a chance to engage with those subject matter experts and ask your questions before you get started on your quality improvement project. So those multiple touch points to help support you along the way.
And it looks like Kate posted the link to the flyer for the collaborative.
I see another question about knowing whether or not we have, I'm going to assume an NPRQI account or not. If you want to email Lisa, I don't know if you want to share your email address if you already have, with your hospital name, we can help look into those records. We have another question about how would this work for a hospital that recently opened a 12-bed pediatric ED but is still staffed by adult providers 16 hours a day. Well, Kate, you want to help address that one?
Sorry, 12-bed ED, 16 hours a day. Yeah, absolutely. I mean, I think it's really just working within the confines of your own emergency department. So, data is typically entered retrospectively, so you don't have to be, working in the ED when you're looking at past encounters. In some EDs, it's the nurse manager who might sit down with their, QI lead if there is a QI lead, or ED medical director, and review a few charts and look at how care was provided into the system, and then look at performance together and be able to share that with the larger team. Um, in terms of, if you're wondering, does care look the same during the 16 hours when we staff versus, the other 8 hours? You could certainly choose to look at baseline performance during those 16 hours and select charts that only or encounters that only occur during that 16-hour period. And then as you begin your quality improvement work, look at how performance might differ during those 8 hours when you're not staffed with, those other specialists. And so that's a way of really being able to say, can we scale this up and identify maybe what are the gaps that are happening? But Sonia, did you have anything else that you would like to add to that?
Yeah, I would agree. I think there's a lot of opportunity for rich data from the 16 hours that are staffed by the adult providers, and also a lot of blind spots that may exist when you have your pediatric specific providers, for example. So I think it would absolutely be a great match for your ED to implement.
Thank you for your question. We had another one come in about ED leadership support is essential for success, but the bottom line supporters are the folks in C-suites. How do we translate PEDS quality improvement readiness into dollars and cents that C-suites then tend to pay attention to?
Yeah, so I think this is similar to the question about financial incentives that was in the chat box too. So, this is really about risk management. And I think more and more we're starting to see, unfortunately, lawsuits related to system readiness. And there is no program in the country that can, tout such huge decreases in mortality risk as pediatric readiness. To see a 76% decrease in mortality risk for critically ill children and a 60% decrease mortality risk for critically injured children is enormous. And so I think the financial incentive or how you sell this to leadership is really about risk reduction, about risk management, and about ensuring that we're able to meet the needs of all children. Because what we have also found, and I'll just add one more piece to this in the literature, is that the average time it takes to transfer a pediatric patient exceeds the average time to death in those critically ill and injured children. And in fact, the great majority of children who succumb to their illness or injury do so within the first hour of arrival. And the opportunity to stabilize and manage those emergencies is immediate, not get them packaged up, transferred, and hope that they survive. So it really is about risk management and mortality risk reduction.
Thank you for the question. And I see Sonia shared with you all in the chat some of our promotional material targeted towards your C-suite. A couple more questions. Do you know how hospitals typically support this work from a personnel standpoint? Is it usually a bedside nurse, PEC, that is responsible for submitting the data when they have time, or do you have suggestions for what that looks like?
You can take this one. We've seen such a wide variety of participating site kind of structures. Some sites will have, a couple of people that are part of their team. So they'll have someone who is a nurse leader who can think through the strategies and think through the interventions, but may not have time to do data entry. And so they'll have a couple of nurses or other clinical staff that will just enter charts for them. But quite often we have a single person that enters data and kind of takes on initiatives because that's just what's available. And then the way we can tailor that to your hospital is really by ensuring that you are not, for example, spending all of your available time entering data or all of your free time entering data. There are really smart ways for us to sample data and have it match kind of the resources available to you and still get kind of meaningful knowledge and information from it. So we absolutely can work with you regardless of resources to make this.
Thank you, Sonia.
Oh yeah, I
I
see the next question by Erin. Should I go and answer that one too?
Yeah, is there any concern for EDs with too little of data? I would like to increase our pediatric readiness, but worry about having enough data as we see less than 300 patients a year, pediatric patients.
Yeah, honestly, if you enter your 300 charts a year, that is plenty. We need 10 charts to get a data point on the dashboard for the table. And then for every point on the graph, you need 10 charts. So even if you entered 10 charts a quarter, that's 40 charts a year, you could still get a meaningful kind of graphical view in a dashboard. So we can coach you all through, and this is part of the collaborative or through office hours with us, coach you all on how to sample your data systematically. So when you're sampling charts, when you're not entering every patient, it's really crucial to ensure that you are sampling in a very non-biased way, so that even if you enter those 40 charts, they are largely representative of what happens in your ER. So that's something we can coach you through. But yes, if you can get 10 charts a quarter, we could still get some meaningful numbers for you.
Really great questions. See another one about asking if today's materials will be shared. We will be sharing those with you all by email after today's session. A question from Elizabeth. Is this all manual entry or does the website have the capability to integrate with an EHR to set or pool data?
The EHR pool is something we are really wanting to work towards, but we don't have that ability at this time. So for now, this is all manual data entry and NPRQI.
But I will add two things to that. That is the same way that stroke and STEMI patients and trauma patients are currently monitored in terms of quality improvement first. But secondly, we are actually going to start piloting this work and developing the electronic data entry in the first quarter 2026. So if your site might be interested in serving as one of our pilots for electronic data entry, we would still encourage you to join us and we can work with your site as potentially one of our first sites of working through that. So.
Well, very exciting development. Right. What other questions do you all have? And we have that Q&A feature, or you can raise your hand and come off mute. Right, and then on the screen we have a QR code to help you get started and begin registration today. If that's not already been shared in the chat, we'll put it there. If I don't see any other questions, I think we'll hand things back over to Sam to wrap it up.
Awesome. Thank you all so much. I learned a ton today, and I know I've been to many of your sessions in the past. I'm so excited that we had such a great turnout, and thank you to everyone that attended today. I'm going to share my screen real quick, just so that our attendees can also see how to contact their state partnership managers real quick. Sorry. I'm working with some technological deficits today. So can someone let me know if you see my screen, which should be the list of our contacts?
Yes, we can see it.
Awesome. Thank you so much. So I'm going to just take a moment and just go down the list. Most of our managers are on the call today. Some may have had prior obligations. Hopefully, most of you got invited by one of us, but you never know. Sometimes we have really big listservs and we have a great turnout. And I think it would just be a huge miss if we didn't get to hear from each of the managers briefly. If you guys want to just come off mute when I call your name, if you have something you would like to share specific about how your state is supporting NPRQI or how you might require it in any of your pediatric readiness work, or any words that you'd like to say to your attendees, I will just get started with Kelly.
I'm sorry. I was reading an email. Sorry, Sam.
Oh
Could you
gosh,
please?
sorry, Kelly. Nope, you're all good.
Yeah. Kelly Jones. I am the program manager here in Illinois, and very happy to help provide guidance and assistance, and happy to have everybody joining us today. And did I miss anything?
No, you're totally fine. Just if you had
Okay.
anything specific for your state, and you guys don't have to feel obligated, it's just an opportunity. Some of our states are requiring participation with NPRQI, or they might have
Yeah.
something specific to kind of tune in, especially with
Yeah.
the NPRP assessment launching soon as well. So, yeah,
Right, right. Yeah, well, it's voluntary. We are highly encouraging, and we do have several hospitals that have gone through the process, and Lisa has done such a phenomenal job of resourcing and coming out and helping virtually numerous times with our regions and statewide as well. So thank you for that. So thanks.
awesome. Margot, Vicky,
Thanks, Sam.
Margot, go ahead.
Hi,
Yeah.
it's sorry, I can't get my video to come on. This is Margot Knefelkamp from Indiana, and in Indiana, it is voluntary. It's great to see so many from Indiana on the call today. And if you have any questions, please don't hesitate to reach out, and we look forward to you joining us. Thanks so much.
Thank you, Vicky. There was me just for a minute. Hey, this is Vicki Peterson. I am the program director for Iowa EMSC, and I just wanted to tell you that I know that QI works. I know that naming quality indicators and tracking them works because we see it in our pediatric recognition program for hospitals. It really makes a difference. It really ups the game. And that translates into saved lives. So that's super important. I very much respect and support this venture. And if anybody from Iowa has a question or would like some assistance, please reach out and I will help you get the answer. Thank you, Vicki. Next is me. So for my Michigan friends out there, thanks for being here. Some of you may have heard about the NPRQI over the last few years in collaboration with our Michigan Center for Rural Health. We've been working to really make sure this is known by our rural and critical access hospitals. We, of course, want everyone to be able to use it, but we really see a huge advantage to our smaller hospitals. I hope you found today encouraging. I've been reached out by many people, and I do want you also to know that we have the opportunity in Michigan to look at a statewide and some regional dashboards. So if there's any of our folks that are working from a healthcare coalition or regional perspective, we do hope to get enough hospitals participating in Michigan where we can have some even more robust pediatric data to help us with our pediatric readiness work groups that happen at a regional level in the state. And then down the road, when we have a fully functional pediatric readiness recognition program, we do plan to include participation with NPRQI for our rural and critical access hospitals. So if you're an adopter now, you'll be ahead of the game and reach out anytime. I'm going to hand it over to Chelsea. Or Regan.
Hi everyone, my name is Reagan Blackwell. I am the program manager in Nebraska. I just want to say thank you so much for being here and taking the time to learn more about QI and this initiative. I'm really excited to be a part of it and to help anybody in Nebraska that is interested. I'd love to just help field your questions and get you resources that you need. And in Nebraska, this is totally voluntary, but excited to improve pediatric readiness initiatives.
Thank you. And Regan, I'm sorry I said Regan. One of my best friends is Regan, and I read your name and I always say it wrong, and I'm so sorry.
No worries.
All right. Thank you. Next up is Chetty.
Hello, I'm the North Dakota person, and thank you to everyone, but a special thank you to my North Dakota people because clearly you're my favorites. So if you have any questions, if I can help any way, let me know. My contact is right there. Thanks.
Thank you. Next up is Kyle.
I'll put a note in the chat. He's having some technical difficulties, but he did send some well wishes to the Ohio attendees.
Beautiful. Thank you. And Corolla.
Good afternoon. Thank you for attending the EIIC and thank you to the EIIC for hosting this amazing QI collaborative and jumpstarting our process as we move towards the NPRP or Ped Readiness survey that we have coming up in March of 2026. If you have any questions or needs, please feel free to reach out. And thank you to our South Dakota attendees as well. We appreciate everything you do.
Thank you. And last but definitely not least, we have Carissa.
Hey everybody, thanks for joining this afternoon. I see a couple familiar names in the attendee list, so thank you to all my Wisconsin folks. This isn't required in Wisconsin; it's completely voluntary. But I will say, through our ED facility recognition program, I have seen some previously participating EDs utilize the NPRQI resources as part of their documentation for their QI process. So it has been really beneficial, and we've seen some of their efforts really come to life. So I highly recommend participation if anyone has the time to do so. And if you have any questions, please let me know.
Thank you. All right, I'll hand it back to our NPRQI friends. Thanks for allowing us just a few moments to, say hi to our different attendees. It's pretty exciting to see so many people from different states getting together, and a lot of our Midwest PECs actually do a lot of collaboration together. So we are really thankful to you guys for allowing us this opportunity for a special session. And I really love the questions that came through. I'm going to hand the mic back to you guys to wrap us up, and we'll look forward to sharing resources with the attendees in partnership with you guys after this event is concluded.
Thank you so much. We appreciate the opportunity to share with you all today. And if you have any additional questions, obviously our state partnership program managers are a great place to start. But you can also reach out to Lisa or I with any specific NPRQI needs or questions about the collaborative. I don't know, Kate, if you have any closing remarks.
No, just really appreciate everyone's enthusiasm for pediatric readiness. We really hope that you find these resources and the QI Collaborative helpful. Thank you for your support to all of the EMSC state partnership managers. And if you have any feedback, challenges, struggles along the way, we certainly welcome that. This is, intended again to really drive improvements and are grateful for the time. So wishing you all a happy holiday season and thank you again for allowing us to join.
Right. Well, thank you all and have a great rest of your day.
Thank you.